so we can go to Sinai.
Thanks, Noor. Okay, can you guys hear me?
Yeah.
Yep.
Okay, perfect. So welcome everybody. This is the last case for today. So we have interesting filter removal. So in the room today we have Christina, Toyin, Dr. Nowakowski, techs and nurses as well. So I want to thank everybody again for helping us with all these live cases, and also the AV crew to help us with getting all these cases shown to you guys. So Christina's going to introduce the patient.
Thank you so much, Dr. Patel. So today I'll be presenting a case of an IVC filter retrieval. Next slide, please. So this patient is a 61-year-old male with a past medical history of right lower extremity DVT, now in Eliquis, who was found to have a chronic subdural hematoma after a mechanical fall in March and had an IVC filter placed after MMA embolization. He recovered well and was discharged home. We placed the IVC filter in March, and right now he's currently taking a Pixaban BID and tolerating it well. And so he presented today for evaluation and for IVC filter retrieval. His other past medical history is unremarkable, and he's no known drug allergies and currently taking a Pixaban. Next slide. So for his vitals were within normal limits. His physical exam was unremarkable, labs unremarkable also. And the imaging I'll show on the next slides shows the positioning of the IVC filter on placement and then after 3 months. So next slide. So this was when we initially placed the IVC filter. We placed the IVC filter from right common femoral vein access, and the filter looks to be really in good position, straight up and down. Okay, next slide. And then on follow-up imaging that he had performed in June for other unrelated reasons, we were able to see that the filter appears to have a lateral tilt now. So next slide. So in summary, this patient is here today for evaluation for IVC filter retrieval with our imaging showing a laterally tilted IVC filter. So today we're planning to attempt retrieval of this filter via right internal jugular venous access.
Thanks, Christina. So, sort of a standard case here for I think for a lot of people is a filter placed. We place primarily option filters. That's sort of our filter of choice. Can we show the fluoro safe here? So it's a little zoomed in, but you can see sort of the image of the filter, which we always start before we do a filter removal. We do a single shot of the filter just to make sure all the legs are there and everything. But you can see still this sort of lateral tilt that Christina was explaining. We do a venogram again. It looks like it's centered, but we don't see any clot within the filter, no clot above the filter. It looks relatively good. Again, we tried to do it with the snare here, and you can see we're not really engaging it. We tried a couple different maneuvers. We can get next to it, but the hook seems like it's touching the wall, and we're unable to really engage the hook. So now we're sort of left with, what do we do in terms of escalation of the procedure from here. So I'll tell you what we're going to do just so we can keep moving here. So we put an 18 French sheath down, and our plan is to use the forceps. So if they can show this here. Let's see. Okay, so yeah, so these are our standard sort of Lymal bronchial forceps. They come straight. They're ours because they're always tilted. I don't know if you can see the whole thing, but it's tilted a lot because they get re-sterilized and reused. We tried the Cook snare. We had the Cook retrieval kit, and that didn't really get us around it. So we've already pre-tilted or pre-bent the Lymal forceps here, and so we're going to go ahead and try and start removing the filter here. So Dr. Nowakowski is going to go. You want to make sure your hands. So I'm just sort of curious from the panel here. So what would you guys do or attempt and try to get this thing out?
Definitely forceps. You have the right groin prepped?
We do have the right groin prep just in case.
Sometimes if I'm having a hard time with the forceps, I'll try to put an Amplats up from below, see if I can straighten it out a little bit, and then maybe have a more favorable angle. But I think, you tried the snare, and I don't mess around with too many other things before just going straight to forceps after a simple snare retrieval fails.
Yeah. So I mean, the other option that we had talked about a little bit was to do the hangman here, but it's I find it not super fun with these kinds of filters. I think for trapeze and stuff, I think the hangman works better, or maybe like a well embedded green field that works better. But you can see what Dr. Nowakowski is doing is we use the bend and we open the alligator forceps, and we're basically sort of using the alligator forceps as we spin it a little bit to sort of pop the top off the wall, and then what it does is it'll sort of click into the mouth there, and what he'll do is he'll try to sheath over it. Sometimes you get lucky and it goes right in. Sometimes you get a little unlucky here, like Dr. Nowakowski is, and it doesn't quite make it into the sheath. It's sort of next to the sheath. So you can see what he's doing. He's just sort of twisting it and seeing if he can get the sheath to go over the hook. Sure. Which way do you want it? And I'll just try the other way. So again, using different angulations to see which way he needs to go. It seems like it's.
Oh, I think it's outside.
You can see it's still sort of the
it's
hook's
outside.
Yeah.
Rahul, do you guys use laser-assisted retrievals at all?
We did at one point. We haven't really found a good need for it yet. Yeah. We haven't found a real good need for it yet. We've just used the method of pull really hard.
Yeah.
That seems to work fairly well.
What's your heparinization strategy with these patients? You do, you don't?
Yeah, so he's on a Pixaban.
Okay.
And so we're going to give him a little bit more sedation here. He's on a Pixaban. We didn't actually have him hold it. So
Yeah.
typically we don't give more if they're already on it.
Mm-hmm.
So, yeah.
And what size sheath is this?
This is an 18 Cook sheath. Yeah, it's an 18 Cook sheath. The issue is really the length. So you need the 40 centimeter length. It's the only one that really comes in a 40 length to work with the Limal forceps. There's a Gore dry seal, which does come in a 65, but it's a little bit too long for the Limal, the forceps. And then the problem also becomes the, I think you've got a better hook.
You have it nested in something, or it's just that 18?
Just the 18. Yeah, we don't do. Sure.
That looks pretty good.
Yeah.
Shoot some muscle from Scott. It should be good.
Come on, Scott.
They're rooting for you, Scott. You want an extra pair of hands, or?
I don't know. Is it definitely?
Could be off on the side.
It might be off kilter. So there was just a comment from the audience about, do you worry about it breaking? So, these are,
There you go.
they're nitinol. They're a single fused piece of nitinol. So in theory, they don't break, but they do. So what do you guys, if something breaks off, a leg breaks off, what's your plan for that?
I think it's inside. Oh, no, it's out. See? Yeah.
Yeah, it's outside. It has the look of it being outside. You just go, you go fishing for the broken pieces. So if it breaks, it breaks. You get the filter out, and then you go after the smaller struts.
Yeah, this one tends not to break apart just because it's a single laser cut piece of nitinol. But the other ones are somewhat notorious for breaking.
These ones are notorious for getting tilted.
Yeah.
Therein lies the problem. All right.
Oh.
Oh.
Yeah.
Oh. You may have to let it go, Scott. You may have to let it go and then pop it back in.
Sometimes it's hard to snare it at this point because you can't open up the snare.
Around it, yeah.
Yeah.
It's the same problem they're having now. They can't open up the alligator graspers to get it.
Just wants to hang on to that cava, huh?
You want to try the snare now, or?
Scott's
There you go.
determined.
There,
Yeah.
Come on.
Nice.
Here we go. Round of applause for Dr. Nowakowski. All right. So if we can go back to this one again, we know how many legs this one has, so we'll oh, this the other. There you go. So we can see we got all of it. sometimes if it's like really embedded or really tilted, we'll leave a safety wire down here. We were fairly certain we would be able to get it out without having to cause too much damage or difficulty. I don't know if you can tell. You can see sort of right here. You can see a little bit of the tissue growth that's on the end of it.
Yeah, definitely.
Partly preventing us from snaring it. So again, the one other thing we'll do just to make sure for completeness sakes is actually two things. One is we'll do a cavogram, a completion cavogram. Tracer. Yeah, a completion cavogram, and then again we also will do a single shot chest X-ray just to make sure there's no pieces that we get blamed for later. And we'll go from there. So, I guess the question is, what happens? What do you guys do if you can't get it out this way? I would say majority of the times we're able to get it out this way.
I find coming from
What
the
is your guys'
groin
possibly-
and then using another pair of forceps and trying to pull down, pulling down from that frees up the hook from the wall, and that allows you to take the
So
forceps
the
from the top.
dueling forceps sort of technique.
Yeah.
Yeah. All right.
Sometimes a hangman forceps combo
Oh, okay.
can do the same thing, kind of rock it off the side and free up the hook for you to grab.
A balloon along the side also helps freeze up the tip.
Looks good.
Spectacular.
Like nothing was there.
Yeah.
So what do you have in the room in
we'll-
case this cavogram doesn't look like this and you have a perforation?
So we do have a Reliant balloon available, so that's what we would sort of use if this went really sideways. You want to just take a single shot of the chest? Yep. Sorry. Got a new room. Everything's reversed. Here we go. Yeah, so we'll use a Reliant balloon. It's very rare that we have to actually stent anybody. That looks good. Yeah, I fluorescent it. Yeah, so we'll it's pretty rare that we've ever to stent graft somebody. It's almost always with the nitinol greenfield filters that we've like ripped the IVC, and a lot of it's technique related, not so much the filter itself. But yeah, those are sort of our two baillets. We'll put an endograft if we have to. A lot of times you just hold, just use the balloon, hold pressure. It's a low pressure system, and they'll stop on their own.
What's your threshold to put up a balloon? I've had small injuries that we've seen on fluoro and confirmed with IVIS, and they've been small enough that we feel comfortable just not doing anything. So I wonder, what's your threshold to balloon, and then what's your threshold to stent?
So, it depends. So if the patient's more awake, then if they're having a lot of pain or discomfort, then I'll put the balloon up just temporarily. The other, just take this out, right? The other is if obviously if they're becoming hemodynamically unstable. But if it's small on IVIS, usually we'll just let it go.
And this was moderate sedation?
It's a MAC, so we do it with
Okay.
anesthesia. Yeah. We had a decent idea that it might be a little bit more difficult. So if we think we're gonna have to escalate to forceps, we'll do it at least with anesthesia.
Yeah.
They don't usually need general anesthesia unless I think I'm gonna have to rip it from the groin.
Yeah.
Yeah.
Cool. Nice. Good work, guys.
Questions, comments? Thank you. Well, thank you, everyone. And then hopefully you guys enjoy the rest of the meeting. I'm going to try to make it back over for this afternoon, and I'll see you guys then.
Cool.
Well,
Thanks, Rahul.
Great job.
Thanks, Scott.
Thanks,
Bye,
God.
guys.
Bye.